Good morning, everyone. I am Dr. Eti, working as Vice Principal, Professor Head, Department of Oral Pathology and Microbiology, Azizia College of Dental Science and Research. Today we'll be talking about the topic pemphigoid. We'll look into the terminology, the classification, normal histology, pathogenesis, clinical features, histopathological features, differential diagnosis and management of cicatricial pemphigoid and bullous pemphigoid. The term is derived from the Greek word pemphix, meaning blister or bubble, eidos meaning resemblance. So an autoimmune blistering diseases. What do you mean by autoimmune? The main function of the immune system is to protect an individual from foreign or non-self antigen. The immune system could go twisted and instead of reacting with the foreign antigen, the attack will be focused on the individual self-antigen. We'll see some of the terms, the vesicle and bulla. Vesicle is nothing but a clear fluid-filled blister less than 5 millimeter in diameter. Bulla is a clear fluid-filled blister greater than 5 millimeter in diameter. Coming to the classification of vesiculobullous lesion, infections, the viral infections, immunologically mediated diseases, hereditary diseases, allergy. Then based on the split in the anatomic planes, that's a FITZPATRICK classification. It can be either in the subcorneal layer, the spinous layer, suprabasal or basal layer. This is within the epithelium, or at the dermal epidermal junction. So our discussion will be only on the bullous pemphigoid and cicatricial pemphigoid. Now coming to the histology of the normal oral mucosa, you have the epithelium, the lamina propria, and the deeper connective tissue with the mucous gland, the submucosa. The composition of submucosa differs in the different regions of the oral cavity. The junction between or the interface between the epithelium and the connective tissue is the basement membrane. The counterpart in skin is the epidermis. The connective tissue is known as dermis and contains dermal appendages. Now we'll see what is basement membrane. The ultrastructure of basement membrane is known as basal lamina. It has lamina lucida containing the bullous pemphigoid antigen, the glycoprotein. Then lamina densa having the type 4 collagen coated with perlecan, and sublamina densa type 7 collagen inserting into the densa, and looping through the type 7 are type 1 and type 3 collagen. Coming to the structure of the addition matrix, that is a hemidesmosome, it consists of a transmembrane protein, cytoplasmic adapter protein, and to the intermediate filament. The transmembrane protein belongs to the integrin family of addition molecule. Here what you see is alpha 6 beta 4. It binds to laminin and bullous pemphigoid 180. And the cytoplasmic adapter protein BP230 and plectin forms a dense plaque on the cytoplasmic side of the hemidesmosome, and they function as an attachment for the intermediate filament, that is a keratin filament. This is a list of the subepidermal blistering diseases. We'll focus on bullous and mucous membrane pemphigoid. Coming to the cicatricial pemphigoid, also known as mucous membrane pemphigoid, ocular pemphigus, because those are the regions commonly involved. Why the term cicatricial? It is derived from the Latin word cicatrice, meaning scar, because here the lesion heals by scar. It's a rare disorder. Incidence varies between 0.87 per million per year to 1.16 per million per year. Coming to the pathogenesis, here the autoantibodies are directed against the BP180 and the laminin 5, that is 332. The laminin is a heterotrimer having alpha 3, beta 3, and gamma 2 with a D-chetomine. Here, The BP180 spans the lamina lucida, and the non-collagenous portion is known as the N terminus, and the collagenous portion, that densa, is the C terminus. In cicatricial pemphigoid, the autoantibodies directed against the C terminus. So split is at the deeper level, and the basement membrane is attached to the epithelium. Coming to the clinical features, usually between 40 to 50 years adults. Females affected twice as frequently as a male, and commonly involved is oral mucosa conjunctiva. In skin, only 25% of the cases shows involvement, the two around genitalia and near body orifices. You can see the blisters over the skin, and they heal by scarring. Other mucous membrane involved are nasal, laryngeal, pharyngeal, esophagus, vulva, vagina, and penis. Ocular involvement is a serious complication. As you can see here, addition develops between the bulbar conjunctiva and the palpebral conjunctiva. Symbalpharynx and ankylopharynx, there is addition develops between eyelids, difficulty in opening the eye. Corneal ulceration leading to blindness. Other complication, oral mucosa rarely scars. There is addition formation, there is limitation in movement, loss of gingival tissue, alveolar bone loss, and tooth loss. Nasal discharge, epistaxis, chronic sinusitis scarring, and there is impaired airflow. Hoarseness and loss of voice, stenosis, that is narrowing of the passage, lead to airway compromise. Dysphagia, difficulty in swallowing, painful swallowing, that is odynophagia, aspiration, and stricture formation. Coming to the oral manifestation, you have a thick-walled bulla. It stays on for a day or two before it ruptures and gives an eroded area. In the case of pemphigus, the blister or the split was within the epithelium. So the roof of the blister was thin, so it ruptures very fast. While in the case of pemphigoid, the blister or the plane of split is subepithelial. So it's having a thicker roof. So it stays for a day or two before it ruptures. So once it leaves a eroded area, and the gingiva, after healing of the erosions, still you can see an erythema persisting for weeks or even months. The oral lesion rarely scars, and this involvement of the gingiva is known as desquamative gingivitis. There are other causes apart from pemphigoid, like pemphigus, lichen planus, or the desquamative gingivitis. You have a list of differential diagnoses. That's pemphigus, erythema multiforme, bullous pemphigoid, epidermolysis bullosa, acquisita, linear IgA, bullous dermatosis, bullous SLA. So you have intraepithelial blisters and subepidermal blisters. Now, how will you make a diagnosis? You have to go in for a biopsy, take the perilesional tissue and submit for histopathological examination. For the light microscopy, put it in 10% formalin. For immunofluorescence, put the specimen in a transport media, that's Michael's media. For the indirect immunofluorescence, the sera of the patient can be used. How will you make a histopathological diagnosis? Seeing the level of split, the mechanism responsible for the split, look for the inflammatory cell component, look out for also the other features like Schwann cells, multinucleated giant cells, civet bodies, satellite cell necrosis. So see Schwann cell and all in pemphigus, Schwann cell, multinucleated giant cell, viral lesion, civet bodies, and lichen planus. What is the anatomical split? If it is in the granular layer, pemphigus foliaceus. If it is in the spinous layer, herpes. If it is the suprabasal, pemphigus, and basal layer, erythema multiforme, lichen planus, lupus, and simplex, EB simplex. If it is subepidermal, you should think of, if it is lucida involved, then bullous pemphigoid, cicatricial, epidermolysis bullosa junctional, dermatitis, epiphytis. If it is sublaminar densa, that is epidermolysis bullosa acquisita, dystrophica, linear IgA dermatosis, and bullous lupus. Then mechanism, if there is ballooning, you think of viral lesion. If acantholysis, then think of anything which causes intraepithelial split. Then basal cell degeneration, basement membrane zone discretion, think of a subepidermal blistering disease. Inflammatory component, if it is subepidermal blister with little inflammation, think of epidermolysis bullosa, bullous pemphigoid, non-inflammatory type, and 10. Subepidermal blister with lymphocytes, erythema multiforme, paraneoplastic pemphigus, lichen planus, pemphigoides. If it is with eosinophils, think of bullous pemphigoid, pemphigoid gestationis, that is nothing but a variant of bullous pemphigoid occurring in pregnancy. Also, drug reactions. If it is with neutrophils, linear IgA bullous dermatosis, cicatricial pemphigoid, bullous LE dermatitis, hepatiformis. In histopathology, for this, you just look at this for the HNT. Okay, you see no acantholysis, but there is a subepidermal split and some non-specific inflammatory infiltrate. You can't make a diagnosis what it is by just looking at the HNT. So you have to go for immunofluorescence for a definitive diagnosis. Here you can say it only as a subepidermal blistering or a subepidermal vesiculobullous lesion or subepidermal blistering diseases. What is immunofluorescence? Like that is you tag up the antibody with the fluorochrome so that you can see the antigen antibody reactions. There are two types of direct and indirect. Direct is done on the mucosa, indirect is done in the patient's serum. Here, the mucosa, you tag the primary antibody, that is anti-Ig is used. So it will go and bind with the Ig. And if there is a positive reaction, you can see the fluorescence. In the sera, you have the circulating antibodies. So use a normal mucosa, it goes and bind with the antigen. And if at all there was an antibody, then when you use a secondary antibody, which is tagged with a fluorochrome, it will go and bind with the primary antibody. So this is a step in it, and you see the fluorescence, positive fluorescence here. Then another modified IIF is a salt split technique. You immerse it in salt for a day or two, 48 to 72 hours. So you create a split between epithelium and the connective tissue, as you see here, and the split is along the lamina lucida. So antibody is depositing on the roof here. In this case, it is depositing on the floor. So accordingly, you can identify which is a blistering disease. Now doing a direct immunofluorescence cicatricial pemphigoid, you can see the deposition of immunoreactants along the basement membrane zone, giving a shoreline-like appearance. Indirect immunofluorescence is positive only in 5% cases, indicating lack of circulating antibodies in cicatricial pemphigoid. ELISA for the presence of anti-BP 180 C-terminal domain and anti-laminin 332, but is helpful in diagnosis, but this is not readily available in all the laboratories. Treatment, you have to see that you don't develop new blisters, because if blister occurs, then it heals with scarring and leading to complication. Give topical steroid, mild case give systemic steroid, then in severe case steroid with immunosuppressive, then another modality is immunotherapy. Bullous pemphigoid, also known as parapemphigus, first described by Walter Lever in 1953, and the circulating antibodies was demonstrated by Jordan and Buettner in 1967. Most common of the autoimmune blistering disease in elderly people. So genetic predisposing factors such as class 2 HLA, HLA-DQ, beta 10301, and environmental influence such as UV radiation, trauma, and trans. Pathogenesis here, the autoantibodies directed against BP 230 and BP 180. I said you previously it is the antibodies directed against the N-terminus, that is a non-collagenous portion of the domain, which is closer to the cell membrane, basal cell membrane. So here the split is occurring at the higher level, and here the basement membrane is attached to the connective tissue. Coming to the clinical features, it has a limited course and seen in elderly over 60. There's no gender predilection, and the lesion occurs either on the prodromal skin or in the normal skin. As you can see here, the vesicle and bulla. What is a prodromal? It's nothing but premonitory signs. That is, the eczema, the rashes like eczema urticaria develops. Then after weeks or months, slowly the bullae vesicle start appearing over this rash. This is thick-walled, the bullae and all, so it remains for a day or two before it ruptures and leave raw eroded areas as seen here. Then oral involvement less frequent, 10 to 45% cases only. You get vesicles, erosions, ulcerations. Gingival show erythema and it may desquamate even after minor trauma. Patients will say that brushing is difficult, it's bleeding and pain. So vesicle erosion is also seen on the buccal mucosa, palate, floor of the mouth, and tongue. Histopathology HND, you can see a subepidermal split. Here, basement membrane is attached to the connective tissue. In the inflammatory component, you can see the eosinophils. In the bullae also, you may see eosinophil, and this is characteristic. Direct immunofluorescence is carried out. You can see the immunoreactants along the basement membrane zone. That's IgG and C3. 40 to 70% show circulating antibodies. So you can do direct immunofluorescence also, a salt split technique. And here you see the immunoreactants in bullous pemphigoid is deposited along the roof of the blister. In epidermolysis bullosa, it is along the floor. So you can distinguish between bullous pemphigoid and epidermolysis bullosa by doing salt split technique, because both are subepidermal blisters. Coming to the subepidermal, we have covered the subepidermal blisters. In this, if it is linear and involving the basement membrane zone, if it is IgG and C3, in the salt split Ig is deposited in the roof, it is bullous pemphigoid. If it is in the floor, it is epidermolysis bullosa, bullous SLE. If it is the IgA deposit, linear IgA disease. If it is granular IgA, it is dermatitis herpetiformis. Treatment for bullous pemphigoid, topical and systemic corticosteroid, also immunosuppressive therapy, targeted immunotherapy. Prognosis is good because the patient experiencing remission after 2 to 3 years. The amount of anti-BP180 IgE in serum is associated with disease severity. To summarize, the diagnostic criteria for MMP, that is mucous membrane pemphigoid, you see tense blisters on the mucosa. So direct immunofluorescence showing immunoreactants show line-like appearance. In serology, anti-basement membrane antibodies detected. ELISA immunoblotting can be used, and you can see the subepidermal blister in HND. The diagnostic algorithm of bullous pemphigoid, the clinical, you can see that there's in enderly, it is absence in head and neck involvement, absence of mucosal involvement, there's no atrophic scars. You can go for BP180 ELISA for monitoring the severity of the disease. Then you can see that in immunofluorescence, it is deposited along linear IgA, along the basement membrane zone. And you can see in the salt split technique, the staining is on the roof. Also, for the antigen mapping, you can see N serrated pattern in bullous pemphigoid. Thank you.